Hi, good evening to all of you. So, we planned for the part 3 session on recall and to discuss the questions. So, a set of questions which are straightforward and simple and on general topics and all the sessions which closely encompass and cover what we did in general topics during our discussion in the class. So, the question here, first you ascertain this question and options are correct. Stage 2 empyema management, antibiotics and drainage, open decortication, vast decortication. So, C and D almost are the same. Is the question right? And if the question is right, and what is the answer? Yes, please. I need your active participation. So, the answer is antibiotics and drainage, because the stages we should know, and thoracotomy. Yeah, open decortication is done by thoracotomy only. So, anyway, stage 2 is not going to be done by thoracostomy. So, thoracostomy was there for what? Instead of open decortication, or for which option? Instead of open decortication, it was thoracostomy. So, even in spite of it, the answer remains the same. So, it does not change. And Subiston 21st edition very clearly says, when the empyema presence in de novo usually follows pneumonia. Okay, and there are 3 phases. Exudative phase. Exudative phase causes the lung to be trapped with a thick peel or a cortex, for which a surgical management may be required. The treatment of empyema depends on the extent of the disease and its location, and complete drainage is required. Antibiotics and supportive care are commonly initiated in uncomplicated pleural space. Complete drainage can be achieved by an ultrasound guided. Once again, I am sorry, the slide changed. In exudative phase, so there are 3 phases of empyema. I am sorry, Subiston 21st edition, page number 1630. And exudative phase, this is a protein rich in more than 30 gram per liter of effusion. If this becomes infected, the organisms from the lung is typically streptococcus, haemophilus in children, and the scene is set for empyema, and at this stage antibiotics may be required. Aspiration or drainage or to the dryness addition is preferred. Phase 2 is over. Subsequent days, fluid thickened to what is known as fibropurulent phase, and the drainage of this stage is purulent, as antibiotics on their own is unlikely to be curative. So, this is what has been asked in the exam. So, the answer will be drainage plus antibiotics. Now, the third phase is the organizing phase, where the lung gets trapped, the thick peel of a cortex, okay, and the pleura becomes thickened, and where you need to do a decortication, for which a surgical management is required. Okay. So, these are the 3 phases of empyema, and phase 2 was asked. So, the answer will be, in phase 2, it will be abscess, a collection of infected pleural fluid and abscess formation, so to be drained along with antibiotic. Okay. So, antibiotic with or without drainage for stage 1, and stage 2 definitely a drainage with antibiotic will be required, and stage 3 decortication, either open decortication or VATS assisted decortication. Is it clear? Is the answer and explanation for this question is clear for you? Okay. So, this is for 1, this is for 2, stage 2, phase 2, and this is for phase 3. Normal CVP, very straightforward question from general topics in surgery. Yes, even this question can be answered without preparation also. So, the right answer is 5 to 8 mm of mercury, and so Schwartz 11th edition, page number 439. So, in this part what we are discussing, there are a couple of questions which are asked in Schwartz textbook of surgery, and directly measured and derived hemodynamic data obtained bedside by pulmonary artery catheterization. So, CVP normal range will be 0 to 6 mm of mercury. Okay. So, among the options given here, option A is the most appropriate answer. Okay. So, you can see. So, all the parameters, the factual parameters are given in this tabular column in Schwartz. Okay. So, if this is clear, next we go to the Harris-Benedict equation, and is based on what? It's a factual general surgery questions. Factual general surgery questions. So, the right answer is age, sex, weight and height. See here, Schwartz 11th edition very clearly says 258 page number. Calculating appropriate caloric need for burn patient can be challenging. A commonly used formula in a non-burn patient is Herrick-Benedict equation, which calculates the caloric needs using factors as gender, age, weight and height. This formula uses an activity factor for a specific injury, and for burns, the base and energy expenditure is multiplied by 2. Harris-Benedict equation may be inaccurate in burns with less than 40% of total body surface area. And in this patient, a Curie formula may be more appropriate. The formula estimates the caloric needs to be 25 kilocal per percentage plus 40 kilocal of percentage of total body surface area. Okay. So, let us go back to the question what was asked. So, age, sex, weight and height. So, is it not from line to line from Schwartz? Yes, word to word and line to line. Correct? Very clear. Okay. PSA is produced by all except kidney, adrenal, breast, bone marrow. So, what was your answer? So, we know that prostate specific antigen is predominantly with respect to only prostate, but there are additional organs which can produce this has been documented. Yes. So, it is except bone marrow. Now, here you can see, does adrenal gland produce PSA? So, it's PubMed NCBI, it's given, it's an internet source which I took, which conclude that in addition to breast tumors, okay, and normal breast, colon, ovary, liver, kidney, adrenal and parotid can also produce PSA. Is it okay? So, I couldn't find a reference for bone marrow, so the answer becomes bone marrow. Is it all acceptable to you? Does methylprednisolone, dose of methylprednisolone in spinal cord injury as per NACIS 3 criteria? What should be the answer? Again, this part 3 are of more factual questions. What did you attempt? What was your answer? So, the right answer is 5.4 milligram in 48 hours. So, submission 25 edition, page number 400. So, NACIS 3 will have methylprednisolone of 5.4 milligram per kg to 48 hours. So, corticosteroid therapy in a spinal cord injury has been well studied and remains a controversial. Several large randomized trials have demonstrated more motor improvement at 6 weeks and 6 months following methylprednisolone administration if initiated within 8 hours of injury. Functional recovery is similar to whether methylprednisolone is administered as bolus infusion for a duration of 24 or 48 hours in patients receiving treatment within 3 hours or 3 to 8 hours after injury respectively. Patients treated for 48 hours demonstrated higher rates of severe sepsis and severe pneumonia, although mortality was not different. So, taken together, short duration steroids remains, see that short duration steroid remains potentially therapeutic option for spinal cord injury, although they should be considered in consultation with trauma and neurosurgical services. So, as per the protocol, it will be taken for 48 hours, 5.4 milligram into 48 hours as per the option which is more appropriate here. Is this answer acceptable to all of you? Is it okay? Bowel injury during lap port incision with a peritoneal contamination, what is the grade of injury? So, I was telling you, sure shot question on wound will be there and class of shock will be there. These are must questions. So, clean, contaminated, dirty. What's your take on this question? Yes, definitely. It is a contaminated, it's an accidental injury and definitely it comes under contaminated classification. So, open fresh accidental wounds. In addition, operation with major breaks in the sterile technique or gross spillage from the gastrointestinal tract and incision in which acute or non-purulent inflammation is encountered, including necrotic tissue without evidence of purulent drainage. So, it comes under contaminated. So, we have already read about clean, contaminated and dirty. Okay. So, this very clearly comes under contaminated wound. Okay, contaminated. So, vascular basis of this flap, was a similar picture given in your exam and was this options appropriate, and if you let me know if this is right and we will discuss answer. T4 instead of what? Option A was T4, is it? Okay. T4 artery, okay. Is the question okay? Medial pedicle blast flap was for which option? Thoracodorsal instead of acromion thoracic thoracodorsal? Instead of acromonothoracic, it was thoracodorsal. Almost both are same. So, intercostal T4, intercostal T2, A, B, C are correct. What about D? Was an internal thoracic artery, internal mammary artery was there in the question. So, D was thoracodorsal, is it? Acromonothoracic. So, shall I, instead of internal thoracic, can I make it into thoracodorsal? Yes? Do you all agree that option D was thoracodorsal? Okay. So, if it is a thoracodorsal artery, it is a branch of subscapular artery. Acromonothoracic artery is a branch of axillary artery. It's the second part of axillary artery. It gives acromion, pectoral, clavicular, deltoral. Then, if it is, and this is not a latissimus dorsi myocutaneous flap. See, thoracodorsal artery is for LD flap. And if this is the picture which is given, then the most probable answer will be acromonothoracic. And this will not be the answer, and the answer will be acromonothoracic. Okay, and that becomes more appropriate. And in case a different image was there, kindly post to my personal WhatsApp, and I will just go through it and come back to the next. Okay. So, what is the diagnostic feature of CSF Rhinorrhea? And this was a very favorite question of mine and well discussed in the class. Correct. Beta transfer. And it's a straight line to line from Schwartz textbook of surgery, 11th edition, and it is in 1835. The fluid can be sent for beta 2 transferrin testing. A carbohydrate free isoform of transferrin, yes, is exclusively found in CSF. Very, very important. Okay, understood? So, you know about the hollow test and all that. They are double ring and all this are non-specific. But if it is to be CSF, the best specific will be beta transferrin. There is no doubt about it. Metabolic abnormalities, when jejunum is used as a bladder substitution. So, bladder substitution can be ileum or jejunum. Ileum is most commonly used. Jejunum can also be used when you are doing a radical cystectomy. Option D will be also some combinations like this. I mean, I didn't get option D. So, A, B and C. Out of this, what is the answer? Correct. So, it is very, very clear. So, metabolic complication and changes use of different gut segments when stomach, jejunum or ileum or colon. Okay. So, when it is used for jejunum, it will be hypochloremic, hyperkalemic, hyponatremic, metabolic acidosis. Okay. So, you can see here hypochloremic, hyperkalemic, metabolic acidosis. So, these are different combinations. So, I mean, anyway, this will be there for you, will be posted. So, you can just go through for what rest of the organs can give. Snowman appearance is a very straightforward question and a factual question. Snowman appearance of the heart is seen in. Correct. It's a supracardiac TAPVC. So, TAPVC is total anomalous pulmonary venous connections. It can be supracardiac, cardiac and infracardiac. So, supracardiac will have Sebastian also gives, all books will give, there is no specific reference required here. Refers to configuration of the heart and superior mediastinal borders resembling a snowman, and type 1 typically refers to figure of 8 appearance. So, it is a TAPVC, supracardiac TAPVC. Okay. So, this one, supracardiac TAPVC. Head injury with a direct eye reflex and normal indirect eye reflex, what is the diagnosis? Correct. The right answer is ipsilateral oculomotor nerve palsy. So, condition, Sebastian 21st edition again, a condition that classically illustrates the expanding mass lesion in acute epidural hematoma seen after trauma with the skull fracture. Regardless of the source, however, the progression can be similar and has been termed as a rostrocaudal delay to reflect early and late stages, the listed in order. So, all these are there, focal distortion, an effacement of gyre and sulci, compression of lateral ventricle, midline shift, subfalcine herniation, temporal lobe tentorial herniation, third nerve compression. So, third nerve compression will cause unilateral dilated pupil. So, midbrain infarction and durant hemorrhages, both the people will dilate with irreversible damage to the midbrain. Okay. So, it will be for this, it will be an ipsilateral oculomotor nerve palsy will be the most appropriate answer for this question, if the question and options are appropriate and are right. So, they asked you a formula of INR, am I right? See, ultimately, the reflexes are with oculomotor nerve, sympathetic and parasympathetic, only that will matter. So, at every level, whenever you go to the optic nerve pathway, injury to the optic nerve will cause total loss of vision on that side. Then goes to the optic asthma, bitemporal hemianopia, then optic radiation, and either parietal or temporal. So, all those will give various field effects. Okay. Here the right reflex is asked. It's something with respect to the pupillary reflex, and this is the appropriate answer. That is meant only with those supplying the pupil. Pathway is for field effects. So, is this okay? Formula of INR. Was a question on formula of INR asked? So, the answer goes as INR is PT PAT by PTN of ISI, International Sensitivity Index. So, patient prothrombin time by normal reference range of prothrombin time and International Society of Index, and optimal ISI is 1.3 to 1.5. So, previously he was asking about right reflex. So, there is a question here on right reflex he asked, and that is meant only with respect to optic nerve, that is to do with only the correct. So, this is the optic chiasma. Okay. So, lateral geniculate body, optic nerve, optic chiasma and optic radiation, correct? This is the pathway, and this is to the occipital lobe. This is in relation to the occipital lobe. And from there, the circuits from Edinger-Westphal nucleus, and it goes through oculomotor nerve, correct? That is what we have read, goes to oculomotor nerve. Okay? Oculomotor nerve carries what fibers? Sympathetic fibers or parasympathetic fibers? Oculomotor nerve carries sympathetic or parasympathetic fibers? Parasympathetic fibers, correct? Yes or no? So, parasympathetic fibers will cause what? Constriction of pupil or relaxation of pupil? Parasympathetic influence on pupil is for constriction or relaxation? Constriction or dilatation? It will cause constriction. Once it is lost, once oculomotor nerve is compressed, uncal hernia, what happens? Dilatation happens, no? So, the opposite effect is what? Constriction of pupil. Yes or no? So, it will be an oculomotor nerve palsy. Do you understand what I say? Somebody asked a question. You understand now? So, now injury at this level will cause complete blindness of that eye. Suppose this is left and this is right. So, transection at this part will cause what? A complete loss of vision. If there is a pituitary tumor sitting here, an optic asthma, it will cause what? Bitemporal hemianopia. It will cause bitemporal hemianopia. And from there, when you see an optic track, so this is, this is the optic track. This is the optic track and this is optic radiation. And when there is a injury at here, it will cause right and left homonymous hemianopia. Right and left homonymous hemianopia. And when you look into the fibers which are temporal or parietal, parietal is above. So, injury on upper fibers will cause inferior chondronopia. Injury on lower fibers will cause superior chondronopia. Correct? And if there is injury to the occipital lobe itself, yes, and homonymous hemianopia with macular sparing, and if there is a infarction at the tip of the occipital lobe, where it is supplied by the middle cerebral artery territory, and it will be homonymous macular hemianopia without macular sparing. So, these are the stages of injury where various defects in the field of vision can happen. Understood? Whenever something to do with the reflex, it is between the balance between sympathetic and parasympathetic fibers. Hope I have explained to you on this. So, the tip of the occipital lobe referred as to cuneus supplied by the middle cerebral artery territory, if there is an infarct on that, then that patient will have macular homonymous. The posterior cerebral artery territory is injured. The posterior cerebral artery which supplies the occipital lobe, if this is involved, the patient will have field defect with macular sparing, because of macula, the central vision is supplied by middle cerebral artery. Understood? So, these are the various levels what you should know on optic nerve pathway. It's why called weak, see that it is not contracting. See, weak direct eye reflex, it's weak. It is not contracting, it is dilating. If it is contracting, it will have a normal reflex. Understood? Clear? Over a period of time, even it can dilate fully. Understood? And if it is fixed dilatation, then the patient, whether he is surviving or not, is questionable, right? That should be assessed. So, it will be like weak only. Okay, shall we move on to the next? So, INR is over. Pressure in the lower limb on standing. I hope this was a venous pressure which was asked. Am I right? Was this a venous pressure? See, if you know your anatomy well, you can pick up your answer from anywhere. That's very important. Surgery is basis of anatomy, predominantly. Not for factual questions like this, but as per a concept. Okay. So, the right answer is 100 millimeter of mercury. Where exactly is given? It is from Bailey and Love. The question is direct question picked up from Bailey and Love. The venous pressure in the foot vein on standing is equivalent to the height of the column of blood extending from the heart to the foot. Example, approximately 100 millimeter of mercury. So, this session is that you want to know from where this question is picked up, right? That's the reason why we are doing this exercise. See, this meticulous exercise and discipline only will make you win. Yes? So, it is not the class, it's before the exam or during the exam or after the exam. It's how we get prepared for the exam. It's a continuous process. Okay? Good. A patient developed a CSF rhinorrhea post-head injury. He was kept on the conservative management 10 days, but CSF rhinorrhea didn't resolve. What will be the next step? What will be your answer? These are the options, right? You tell me this question, if you could remember, is this the next step or the management of choice? Or the next management option or next step? Bifrontal craniotomy and dura repair was one of the options. For which option I should do? For which one I should do this? For surgery? So, instead of option C, should I write this? Bifrontal craniotomy and dura repair. Okay. So, diagnostic, see, diagnostic endoscopy is the right answer because you see this flow chart. It is rhinorrhea and beta transferrin test has confirmed yes, it is CSF rhinorrhea, and then history of trauma is there. Yes, this patient had a history of trauma. Is a trauma or acute or delayed traumatic or occult traumatic. Okay. So, associated with the head injury, maxillofacial injury, or iatrogenic, conservative management for 7 to 10 days. Okay. Resolved, okay, fine. Not resolved. Okay. Diagnostic nasal endoscopy. Imaging, CT or MRI, MR cysternography, then localize the site and then closure of the skull base defect. Bifrontal craniotomy will be the treatment of choice. I am not saying no to it. Again, the treatment here is also finally surgery only. But before surgery, you should know where exactly is the defect. No. They asked you only the next step. They didn't ask you what is the treatment of choice. I don't know, I missed out the reference to mention here. Treatment of choice is right. I am not denying it. Bailey says, endoscopy, the treatment is to repair only. But before repair, you should know where is exactly the site of injury to do that. Here they didn't ask you the treatment of choice, right? In the question, if they ask you treatment of choice, your answer is right. They asked you only the next step, right? So, next step is algorithm. You need to follow the algorithm. In your question, if they ask you treatment of choice after waiting for 10 days of conservative management, yes, closure is correct, either endoscopic or if endoscopic facility is not there, you do an open craniotomy and closure. There is no doubt. But that was not the question here. The question was, you as per your statement, it is only next step. Next step is to do a diagnostic endoscopy. Cystic adenomatoid malformation, histological hallmark. Yes, please. What's the answer? Polypoid projection of mucosa. Smooth muscle. And cartilage was in one option, is it? In the same. Was smooth muscle and cartilage in the one option or different options? And cartilage. So, the answer is, was epithelium in the option was there or not? No epithelium. So, can you type all the 4 options and somebody can type and just put it here. So, by the time we can go through the explanation which are given there. Previously denoted as cystic adenomatoid malformation congenital pulmonary airway malformations exhibit cystic proliferation of terminal airway producing cyst lined by mucus producing respiratory epithelium, elastic tissue in the cyst wall without cartilage formation. Was there? Presence of cartilage, smooth muscle, all 4 options in consensus. So, I will just go through what is the explanation given. So, based on that we can arrive at an answer. So, that it will match your option, one of the options. So, proliferation of terminal airway producing cyst lined by mucus producing respiratory epithelium and elastic tissue in the cystic wall without cartilage formation. There may be a single cyst with a wall of connective tissue containing smooth muscle. Was this option matches? Single cyst, a single cyst wall with a connective tissue containing smooth muscle. Cyst may be large and multiple type 1, small and numerous type 2, may resemble a fetal lung without macroscopic cyst type 3. Did any option was like this? Single cyst, there may be a single cyst with a wall of connective tissue containing smooth muscle. So, congenital adenomatous malformation of the lung occurs most commonly in the left lobe. However, this lesion can occur in any location and may occur more in one or lobe on the other side. Clinical symptoms range from none to severe respiratory failure at birth. Over time, these malformations can be subject to repeated infections and produce fever and cough in older infants and children. Diagnosis confirmed by CT. For surgical planning, characteristic feature might delineate other bronchopulmonary foregut formation. Prenatal ultrasound suggests diagnosis. Resection is curative and need to be performed urgently. Infant with respiratory distress, severe respiratory distress. Long term, there is a risk of malignant transformation. But this risk occurs over decades and has not been fully defined. As a result, resection of affected lobe is usually performed. Polypoid epithelium was there in the option? Was there a polypoid epithelium as Dr. Pankaj says? Okay, then we can choose that. Then the appropriate answer could be option A. So, these are the possible things that we have with respect to, if smooth muscle, I mean I heard smooth muscle was there in one of the options, right? There was a smooth muscle, right? Probably polypoid projection of mucosa. I think we can choose. I think so. Okay, could be a better answer for among the options given. Okay, because there is a presence of smooth muscle, and when you say cartilage, there is an absence of cartilage. So, and this is also out, this is also out, and only thing is this is available. And there should be one more option, no? What is one more option? Polypoid projection of mucosa we have done. So, we need one more option, no? So, inflammation, okay. I think polypoid projection of mucosa could be the better option, I think so. Post-op lap cholecystectomy, patient develops a bile collection, POD management. I think it's a simple straightforward question. So, any collection POD, it has to be drained if no DT is working. So, the answer will be drained. So, collection anywhere has to be drained, there is no doubt about it. Okay. Patient generally present, Subiston 21st edition, page 15-14, 1 week, within 1 week of cholecystectomy as bile collects and becomes clinically manifested. As discussed above, the bile direct injury, CT should be performed and will show the ascites of the right upper quadrant, fluid filled consistent with bilioma. After drain placement and controlling the leak and infection, endoscopic cholangiography should be performed. So, the drain has to be attempted. Okay. An ERCP to ascertain what is the cause. Was an image like this given to you? Yeah, we do endoscopic stenting after doing an ERCP, after ascertaining what is the cause. But whatever the collection has to come out, all will get infected. So, whatever according to the image, so image based, it is very difficult to ascertain. So, probably on a hemangioma there was a question, and based on that, so it was large. So, you can definitely answer accordingly. So, it is very difficult to take a stand. So, this question, among the options, collection has to be drained, of course, endoscopy has to be done, and to see whether it can be managed endoscopically or you need to reopen, and if there is a leak because of bile duct injury, and it has to be ascertained according to Bismuth or Strasbourg classification, and then plan accordingly. So, according to this picture, I made an answer as impactal hemangioma. So, if the image is different, there is no point. In a post-op patient, elevated D dimer, low platelets, hemoglobin 8.1, WBC is 5000. So, this picture is typically of DIC. So, if the question was like this and the answer is DIC, disseminated intravascular coagulation, DIC will classically be seen. Yes. So, presence of D dimer high in the circulation may serve as a marker of thrombosis or even condition which has significant activation of fibrinolytic system is present. Shortened platelet survival, thrombocytopenia, immune thrombocytopenia, disseminated intravascular coagulation or disorders characterized of platelet thrombi such as thrombotic thrombocytic purpura or hemolytic uremic syndrome. So, this is a typical feature of a DIC. Okay. So, the set of questions I got after that, our discussion of part 1 and part 2, and I did this part 3 discussion. And whatever the question which we have not discussed, you kindly send to me in my personal WhatsApp number. So that it will, so once the questions are there, then it's easy for me to solve it. This solving is not a problem, but to get a complete question is with the options will make a more appropriate discussion. Only with this time we will not be able to discuss anything. We will know, okay, from this area the question is asked, but what is asked, from where is it asked, ascertaining will be difficult. So, I request, and if you have questions with you other than what we discussed in part 1, part 2 and part 3, kindly send it to me. So, I will discuss in upcoming session at the earliest. Okay. So, when are the results expected? I mean, the discussion is over. After the discussion is this, I want to know when are the results expected. Tomorrow? Is it tomorrow we will be getting the results? Eagerly awaiting for the results. Let us see. And will do well. Conservative management is maximum 2 weeks. Maximum. Yeah, it will be used in conservative management. It is a part of conservative management, acetazolamide. Anything other than surgery and repair is conservative only. Understood? Observation is only not doing anything. See, every student who has given an exam will get a seat. But what specialty you wanted matters. That's very important. Understand? So, what specialty in your heart and what you want matters a lot. So, the days are not far. Anyway, we will wait for some more time and do it. Okay, I want to ask you, did you attend the SG discussion class on discussion on questions on gastro from NEET SS? You tell me, was there any CSF Rhinorrhea, possibly CSF cystonogram was done, 2 cm defect was mentioned. Okay. But anyway, the management remains the same. Whatever we have discussed is the line algorithm of management. So, accordingly, wherever it suits, you answer accordingly. So, we are in alignment. So, I was discussing in the general surgery perspective. I just want to know whether there was any discussion that went in different directions. Okay then. So, I wish you great results and let us look for your results in tomorrow or in subsequent days. Until then, see you. Bye-bye. Thank you very much for participating. Thank you.